that we will continue, inshallah, review of pediatric imaging. We focus in the exam side, and we try to find some discussion tips. Good evening, Dr. Marwa and everybody. Assalamu alaikum. So let's continue, and if anyone sure that if anyone want to add something or any important information, he is welcomed anytime. So what do you think about this case? Let's start, and until our other participants join. I think this one is easy. We mentioned it many times, and it's very important in the exam. So what do you think about this is like adolescent girl, and you can activate your checklist, try to find the abnormality, pneumonia, pneumothorax, pneumodiasteinum, consolidation, coarctation, collapse, and start to look in the review areas. Is it easy one, or I should go to the answer? So you will check every side, and the most important start if there is any pneumothorax, pneumodiasteinum. So always you remember when we find like surgical emphysema, and this patient, as you see, is portable. So when you find like surgical emphysema, we mentioned this rule: search for pneumomediastinum. So if there is any air lucency in the side of pneumomediastinum, so we are talking about pneumomediastinum. Okay, is it easy? Because I didn't see the answer until now. The voice is fine. Okay, so this one, it was pneumomediastinum. When you find that some air lucency outlining the left heart border, extend to upper mediastinum, continuous diaphragm sign, we saw it before. Yes, it happened in the older child. It can be in the young child, maybe foreign body, in trachea, esophagus, maybe perforation in the esophagus. Okay, so let's go further until we find any participants or participations from other members. So Marwa, thank you. So you think about bilaterality, bilateral renal tumor in an older child. So it will be the most common one. It will be Wilms tumor. So just you know that the bilaterality in Wilms, it is like 5% in cases. So maybe, yeah, any solid masses. I agree with you. And what you will look for, you will look for the renal vein and the IVC, because the clinician will wait from you to comment in the IVC and the renal veins. And if you go up to the lung, you will try to find the MITs. Then after that, don't forget the association, because he is a child and you are looking for the association syndromes or disorders. So let's revise again what it could be the associations. So something called, yes, Beckwith, Vedman, and congenital hypertrophy. Perfect. Ala, welcome. Okay. And something like aniridia. There is many. Okay. So asymptomatic abdominal mass clinically. And when you find it as a solid tumor, they are talking about Wilms tumor. Rare before 1 year, and most of the cases happen, 5 years, below 5 years, yes, from 1 to 5. The peak in the MCQ will come in 3 years, mostly.
2 to 4.
Okay, I agree with you, but my source is 1, but it's fine. Okay. The CT or MRI, the close sign. The most important we mentioned, the IVC and the renal vein to comment. Don't forget this comment. Also the relationship with the ureters and pelvic cell system. This one is not very common, but it will be one of the differentiation. Welcome, Joanna. Welcome, Sarah. Nephroblastomatosis, it is the precursors of Wilms. Thank you. Yes, Joanna, thank you. It is the precursors for Wilms, and it is bilateral. It comes bilateral, so we should, when we go to the ultrasound, we should search for them. Yeah. Okay, so let's go in this case. This is the differential. Could be with this cystic appearance. When you find some subcapsular fluid collections, and they mention that tumor lobules, it is like more necrotic areas, and sometimes maybe you can find like hemorrhage. The calcification more common with Wilms, like this one, but this one is not. Sorry, the calcification more common in this one. Yeah, as you see, there is some calcifications. So yeah, what I'm talking about. Okay. Also, the vascular and the local invasion is this. In this one is more common, as you see. Maybe this will be the key when you find intracranial tumor, which have better. So this one, they like it in the MCQ. Maybe will not come to you like a question in the short or long, but it can come to you as just MCQ information. It happened with intracranial neoplasm called atypical teratoid rhabdoid tumor. So what this will be? It will be something called rhabdoid tumor. Okay. So just it's not common, it's rare, but they like it in the MCQ because you will find synchronous intracranial neoplasm. So this is could be when you find something like this, you are talking about what is called rhabdoid tumor. Is it clear? So this is what is called rhabdoid tumor. There is another differentiation. It's called clear sarcoma. I will show you. So this one, it will be what is called clear cell sarcoma of the lung, and it is, as you see, there is some lesions in the upper femora metastatic from this tumor. So this 3 differential could be in the pediatric age group. The most common and the most important to mention, Wilms tumor. Okay. This one is easy when you find like a cystic lesion. Maybe I let you to describe. Hala, nice. Perfect. Bladder, within a bladder sign. Shayma, welcome. Yes, erythroceal. And Rabab, thank you. Erythroceal. And this is what is called cobra sign. So cobra head sign. So it is easy one. And search for the double moiety. And remember this Weigert-Meyer rule. the upper obstruction, and lower will be the the flux will be lower, yeah, and upper will be the obstruction. You remember? Lower reflux, yeah. R with R, yes. Thank you, Doc. So Sarah, yeah, nice, thank you. So when you find bladder within a bladder obstructed in lateral trigone, the ectopic one will be inserted inframedially and it's seen with duplication. Okay. Maybe this one is easy one. After he inject the contrast, and you can see the aortic arch, then they won't show you the vascular anomaly here, which compress the trachea from both sides. Yeah. So it is probably like the double aortic arches. Yes. Okay. There's something which is not easy one. This is what is called cross table lateral radiograph. The patient have this air column in the pelvis, as you see. And what you can note here that it can reach the anal side. Yeah, so nice, Marwa. So you can think about anorectal malformation. And you can see that he tried in this age, if you think about, yeah, imperforate anus. So imperforate anus, it is like one of the low obstruction pattern that you search for. And sometimes when he do like this one, distal colostography, this patient with imperforate anus, he developed something called recto-urethral fistula. Yes, Marwa, thank you. Perfect. Ala, nice. So our stars are very nice in pediatric, I see. This one you can expect when you find this low obstruction pattern. The high imperforate anus is associated with the recto-urethral fistula in boys, and if she is girl, then it will be recto-vaginal fistula. Okay. You can diagnose it with something called colostography, as this one, or yeah, voiding cystourethrogram. Search for any associated renal agenesis or ectopia. So something good to know. You remember when we was in musculoskeletal? I like pediatric because pediatric is like revision of all the systems. So you think that this is like review for our end sessions in pediatric in this system. Yeah, all the. So don't forget when you describe it, the most important word to mention. Okay, lytic, expansile, but what else? You want to tell that it is more with the benign aspect or the malignant looking aspect. So how you describe? I agree with all Marwa, Sarah. I agree with you that this one can be subbubble aneurysmal. Yeah, Chayma, nice, thank you. So this what is called narrow zone of transition. So when you describe it, don't forget this because they like it in the exams. You will search for it when you describe narrow zone of transition. And I agree with you that aneurysmal bone cyst will be one of the good differential, especially if you see the fluid level. And you know that is not specific for the aneurysmal bone cyst. It can be with many things, including the sarcomas. We mentioned this already. Yes. The differential diagnosis. Yeah. It can be. So aneurysmal bone cyst can happen in the spine, as you see here. with lytic appearance. It can be look like aggressive lesion in the X-ray, but in the CT maybe it's fine. Okay. Again and again, vertebra plana and pediatric, one of the important differential diagnosis when you find it. And probably they like to show you sometimes the MRI, especially after you describe it. Nice. Shayma, Langerhans, don't forget. I think you will remember lymphoma and leukemia and maybe infection, but don't forget Langerhans. This patient have epidural soft tissue component. So we mentioned this many times. I agree with you all, yes. Raghda, welcome. I see new stars today, welcome. Again and again, when you see pelvis of pediatric patient, you have limited differential diagnosis of 3 or 4. So try to go quickly. Search for if there is any widening in the joints, because this one, it will be the septic arthritis. And if not, then go for the other 3. One of them will be the DDF. And what else? Try to help, or I help you. So look for the capital epiphysis. Is it well formed, or it have any abnormality? Yeah, Marwa, perfect. So the right one, if you look carefully for it, I will try to focus in it. You will find like maybe there is some sclerosis here, and maybe some irregularity. So when you find this, you are talking about births, right? Maybe early stage of births. As you know, there is some stages. So just asymmetry and maybe smaller with sclerosis, then you are talking about births disease, right? The age will be of births around from 4 to 8. So look for the pelvis and try to find the age. If you are lucky, yeah, I think it will not be like 2 years. He will be like more than 5 years. So then you can try to reach your diagnosis. Okay. Later finding, you can find the subchondral lucency and maybe fragmentation, flattening. But the early stage like this one, it will be the difficult. And more difficult if it comes bilateral. Then it will be more and more difficult. Okay. The treatment sometimes reach to something called osteotomy. Yeah. It can be conservative according to the stage and so on. One of the good issues we mentioned last time, some syndromes. So try to describe the spine here. Anything give you a clue what it could be? Yes, when we find beaking, so it could be Hurler or, yeah, so this one is not midline, so it is maybe Hurler type. Yeah, inferior beaking, Shayma, Marwa, Ala, yeah, inferior beaking. So what the other name, if it is midline, what it will be? Morchio, yeah. If it is midline, Morchio. If it is inferior, it will be Hurler type. And here, when you describe it, maybe they can tell you that there is some widened ribs. And as you see, the humeral nex here, it is far from the side of the scapula on both sides. So this is what's called varus. Yeah, so the all ribs تشبه المجداف. Okay, Marwa, thank you. And in Arabic. And this one is called like heart-shaped humerus, humeri, heart-shaped. And the scapula, it can be elevated as well. So this is the mucopolysaccharidosis. And oar-shaped ribs again. And what is about the acetabulum? What happened here of the acetabular angles? Is it increased or decreased? And also you can see the femoral heads, sorry. Is it, yeah. So flared acetabula, and what happened with the acetabular angles? They are increased. Yeah, the acetabular angle increased, and the femoral head dysplastic. So the femoral heads, as you see, dysplastic, and the acetabular angle increased. And again, maybe we can focus in the pelvis. So you have some characteristic in the pelvis, starting from the iliac. So the iliac, is it large or small? As you see, they are small, and the inferiorly they are wide or tapering. They are tapering and decreased, yes. And you can see also again the appearance of the femoral heads, and there is coxa vulga as well. Yeah. Then we reach the hand, which the lovely appearance with, yeah, coxa vulga Sara, perfect. Tapered Shayma, okay. And yeah, there is proximal pointing. Yeah, proximal pointing ends of metacarpals. Yeah, from 2 until 5 carpals, and maybe some small irregular carpals. And the hand gave you like claw hand. Yeah. So all this criteria, this is what is called mucopolysaccharidosis. Yeah. And you know the types already. We mentioned most of the criteria: gracile femoral and iliac necks, dysplastic femoral heads, G-shaped cella, proximal tapering, wide metacarpals, beaking, and it will be central or MM, midline Morquio, inferior will be Herler. It can be there is some focal kyphosis, and the acetabular angles will be increased with shallow acetabulum. Okay. Thank you, Marwa. The trident hand, we saw it in achondroplasia, but this hand with claw hand, it is more in the mucopolysaccharidosis. So just one criteria, if we saw this appearance, it is what's called G-shaped, yeah, G-shaped cella, and you can see that even there is some macrocranium, and there is dolichocephaly. Okay, it is differential diagnosis. Marwa, frontal bossing as well, yes. Let's shift to this one, and let's see what we have here. I see that I can show you this ugly appearance, that there is lateral radiograph. I have session. Demonstrate acute angle cervical kyphosis. Yes, and there is marked something called dural ectasia and some neural foraminal enlargement. Yeah, posterior scalloping. Okay, so this appearance, if you saw it with this bizarre acute angle kyphosis, cervical kyphosis, remember syndromes like neurofibromatosis type 1 would have kyphoscoliosis. Yes, neurofibromatosis type 1. The characteristic is dural ectasia, yeah, and kyphoscoliosis. Yeah, angular kyphosis. Nirmeen, thank you, Nirmeen. Welcome. Okay. The criteria in the skin, neurofibromas, plexiform, eyes, we remember it well. And some bony lesions can be in the sphenoid or long bones. Okay. Yeah. Okay. Boeing pseudoarthrosis Shayma. Nice. Again and again, adrenal lesion in pediatric patient. What is your differential? Okay. You can mention many things, but yeah, right adrenal mass in pediatric. Hemorrhage. Yeah. One of the most important to mention, it will be hemorrhage. And child abuse may be potential cause if this adrenal hemorrhage in older child. So maybe, okay. You will search for the appearance in the ultrasound. You find like this adrenal mass, and it can be calcified as well in the X-ray. Yeah, calcification model. Hemorrhage, perfect. Lipoma can be, yes, but it will be the most important with hemorrhage. Yeah. X-ray pelvis, and you find in the left side something like this one. So dermoid, yeah, one of the important tooth in pelvis, so equal to dermoid. So mature teratoma, calcification in the MRIs, in the CT MRI, fat, and many signs, tip of iceberg, dot dash sign, and so on. But don't forget that maybe in the calcification you will mention, or the tooth appearance, you will mention the dermoid. Perfect. This one for you, I think, is easy one. With this ground glass appearance, this bony lesion, and you can see that sometimes it looks like aggressive lesion, but with bilaterality, so look for fibrous dysplasia. And this is another shape of fibrous dysplasia with have name like cherubism or lentuosis ossea, Leontine fishes. Yeah, okay. Let's shift again, musculoskeletal and with trauma patient, when it is included the one of the forearm bones, then remember what? Remember either Montigia or Gliese. Yes, fractures. So when you find Montigia, then you are talking about fracture with dislocation. So where is the fracture here? It will be in the midshaft of ulna, perfect. And where is the dislocation? It will be where? In the radial head. Yes, radial head dislocation. Yes, perfect. Ala, Raghda. When you go to the, again, the forearm and you find the radius, the fraction in the radius, so you will search for disruption in the distal radioulnar joint. Yeah, so this is what is called fracture Gliese, fracture dislocation. Yeah. Sometimes we can show you something like fetal MRI, then probably talking about congenital anomaly. What?
Open lip schizencephaly.
Yeah. Why you mentioned open lip schizencephaly? Why? Because schizencephaly, yes. Do you like explain more? So there is huge, already huge bilateral open lip schizencephaly, and go and search for the falx if it is present or not. So this one is like the schizencephaly. The cleft always lined by the heterotropic, yes, connected to the ventricle, so open lip, and here it is lined by heterotropic gray matter. The classic location is the distribution of the middle cerebral artery. Presentation of the patient will present by seizures. The bilaterality is more worth than the unilateral one. So the extension from the ependymal, yes, and lined by gray matter. Thank you, Ala. Perfect. Yes. And this one is category of migrational anomaly. So huge lip, okay, schizencephaly. Sometimes they want you to describe something like this. This should be the stomach, and this part should be pylorus, and then you reach the first part and the second part of duodenum. So there is full thickening of duodenum, nice. Thickening of the duodenal mucosa. This patient is pediatric. Then he told you that he have like pain, intermittent pain, abdominal pain, and there is rash in his legs. So lymphoma could be one of differential without this history. Hemorrhage could be. Then we told you, perfect, yeah. Who is talking? Then I can mention your name.
Fawzi.
Fawzi, thank you. So Marwa and Ala, Henoch line purpura, it could be one of the good differential. He can show you again the thickening of what here? What this part could be? I think it's more that it will be okay. Maybe, but I think maybe transverse because the folds it doesn't reach. So yeah, the colon have thickening as well with the duodenum, and you can see the lymphadenopathy here and splenomegaly. So this is what's called Henoch line purpura. So remember that when you see something folds thickening in the mucosa of the duodenum or the colon, and this patient present you with maybe renal disease, maybe lymphadenopathy, splenomegaly. So you are talking about Henoch line purpura with this rash. The main age is 3-7 years, thickening, thumbprinting. So put it like differential when you have thumbprinting in pediatric. We will start the first session now with one case I will show you. And I want some competition between you. I hope everyone will enjoy it. I will just disconnect and connect again to show you the case. Okay. Manage the long cases. So I will start from down until we go up. And I will show you, try to, if you have anything, you can collect the finding in the chat. And I want to see how much you can collect finding. So I don't know, I want to make the competition, then we can give 10 stars for the one who collect most of the finding. I will show you this case in 3 stages. First stage will be mediastinal window, then lung window, then bone window. Okay. So I need your but try to, you will find much finding that more important. So okay, you can start to how to go slowly, and when you find something, just write it, and I will try to help you, sure. So this case come to me, I think her age or his age, yeah, was about below 60. And I want to collect the finding to tell me like one time. Write in chat, and when you are sure, then just send, make enter better. Then I can collect for everyone how much stars he is going to do. And now I will ask you to more concentration, to give you more concentration. And sure, I will repeat it one more time. So then we will go to the other windows. But look carefully now, because it will be the second time. Welcome, Ivan. I see many stars. Hawaii. I like real name, but okay. Shaima, Dabab. Try to collect the finding and send enter when time to tell the answers better, if you like. Feel free to do what you like, what is more suitable for you. But this pattern of question is like a long exam. It is real, it can be real exam case. A bit difficult, but it can be. The time is always limited. Now I will go to the long window, then yes. Then probably the next one will be the bone window. I see that maybe someone wanted to give the finding. Wait, I will show you everything, then give the finding. So again, thank you. Who talk in the microphone? Okay. I can just mute all, then come to you. Okay. So again and again, last time before I shifted to the bone window. Okay. So bone window and I will go from down until last time, and then now, if you would like, you can send the answers. I am checking the answers. Everyone who complete it, just send it, please. Just send it, please. I am waiting our stars. Ivan, send something. Shaima and Rabab, you would like to add something before we announce our big star today for tonight? Ivan, Hawaii, okay, I see. Shaima, Nirmin, okay. I agree that. Okay. So now I will shift to mediastinal window. I try to collect with you the things, right? Ivan, Bob, now it's a bit difficult to collect who tell the answers يعني completely. So at least I see that you are giving pulmonary nodule. Everyone already mentioned pulmonary nodule. And maybe most of you mentioned liver lesion, if I am not mistaken. Nirmeen, you miss what? Okay, Marwa, you miss what? Ala, where are you, Ala? I don't see your answer. Sarah, where are you, Sarah? Okay, I will wait 30 seconds. Try to write all full answer, please. Then it's easy for me to know who will be in one time. Yeah, Ala, mass, laryngeal mass, cervical lymphadenopathy, thyroid nodule, bilateral axillary lymph node, anterior mediastinal mass, pulmonary nodule, right renal mass, lytic bony lesions. I will see. I will go a bit, maybe try to help you. But until now, Ala will be the big star tonight. Okay, because I see most of the answers, but some depressing point that there is big problem here. That there is much. I see that Nermeen told already that there is parotid lesion. Yeah, it can be parotid lesion, but there is glottic and supraglottic mass, and there is soft tissue here and here, almost in all parapharyngeal spaces. This soft tissue can be like masses which is confluent with this one, or could be like, yes, lymphadenopathy as well. And the nodule that you mentioned, Ala, maybe is encroachment from the lesion, or maybe, as you mentioned, maybe something like nodule as well. I'm checking if there is any addition. Until now, I'm still, there is some missing finding, but I'm trying to open way with you. Yeah, some of them are necrotic. This is very nice point that you should mention, and it have like marginal enhancement. Then this is what I wait you to mention, that this mandible, what you like, do you like it? In the bone window, yeah. So there is like another problem here. Do you see it? Yeah. So maybe this again masses going and encroaching upon the bone, yeah, is eroded at least. So we should mention that it's eroded. It can be metastatic process, Marwa sclerosis, perfect rarefaction. It can be osteomyelitis, yeah. But already this patient have like much masses. And the most important when you go to the oropharyngeal and laryngeal tumors, that you know that it present with lymphadenopathy much more the primary tumor itself. Yeah, it can be metastatic. So long questions is like this type. You don't rush. The most important, one of the good important signs that you should follow, the vascular invasion. So try to look with me in this both carotid, and we can go up further and see what's happening here. Can you see now the soft tissue? Much easier that have encroachment about these bones. Yeah. So the left internal jugular vein already like partially thrombosed. You agree? And the right, probably you cannot see it. Do you agree? So this is also you should focus in this, that when you tell the, yeah. And the lung, as you mentioned, most of you mentioned that there is some lung tumor lesions, maybe metastasis. Maybe the big one is this one, which is pleural based, and already the patient have some technical problem that have some motion artifacts. But at least you can mention that there is some bilateral nodules already. And this in the liver, I want to just to tell something, because some of us rush and tell that it can be cyst. Yeah, it can be cyst. But when this patient have primary and it is hypodense, don't mention like just cyst. It can be an ultrasound, not cyst. So better to mention like it's hypodense lesion. Then wait in the follow-up if this patient, for example, take chemotherapy. It could be not cyst, it could be metastasis as well. Especially when you find already that there is a big adrenal lesion, which could be again metastasis. Also the left adrenal as well is not very clear. Let's go to the bone, and I see that some of you catch that there is some lytic areas in the bone, and I think Ala already mentioned it. So I think the big star today will be tonight will be Ala. Thank you. But you missed something, but okay, this is first time, so we agree with you. And also is quick scroll, so it's not like you scroll it for that. Also, you can find something here. Can you see it? Very small, maybe something peritoneal, nodule, maybe metastasis. This type of cases, it's come to you, and you should report everything, because this patient probably, if he's metastatic, as we see, he will take chemotherapy and we need follow-up. And I saw that many people, many of you mentioned already that about the prevascular lymphadenopathy. It's very nice from you. Thank you. So is a nice case, much finding. Try to make, yeah, squamous cell can be, as if we consider it as laryngeal tumor as a primary, and all this lymphadenopathy and even the bone and so on, it could be either local invasion and metastasis everywhere. Yeah, this is one of the, we are waiting the results, but the most important that you have your approach to reach the finding and to report it. So I hope that everyone enjoyed this case, and thank you for all the share. Now time to remove and go back to our presentation. Okay, did you enjoy this case? I hope if you, I will ask you to give me feedback if this type of question is fine. Then we can take like some cases every time, then to train you in this type of practice, daily practice. Okay, which sometimes is important for the exam. This one is easy one. I already show you the sign, which is called in the intussusception. You already can diagnose it in
ultrasound.
ultrasound, perfect, as you see here. And this one, intussusception, can be present again with Henoch-Chulaim purpura. So it can be with the intussusception as well, from the thickening. So it can be lead point for intussusception as here. Okay. Sometimes if you see the spine of this patient with this appearance, what is your differential? Yeah, transient intussusception. Thank you, Ala. When you see the spine of this patient and you have like a clue in this case that this patient did
This operation may be due to
operation
radiation.
for wellness, probably, as we mentioned, the most common solid tumor in this age. So this patient, okay, thank you, Rabab. And yeah, it will be radiation. It changes. So this is what's called radiation. Search for it, and the clue for you will be surgical clips. Marwa, yeah, RCC can happen in the pediatric age group. I ask you, can happen, Marwa? Because you told that maybe left RCC. Can happen in the pediatric age group? Yeah, very rare. So go to the common, okay? Better, because the examiner, if you told him like the first differential, I think he will not be very happy with this. So yeah, Whelm is better, I think. Can we make the discussion here only? I don't understand, Shema. What? We already do this. What? Okay. Okay. So what do you think about this? Without okay, it's just in chat. Nobody. You don't like to. Okay. It depends on you. I think this free talk. So when you need to talk, you can talk. Okay. If you like to just use the chat. Okay, as you like. So what do you think about try to activate your checklist and to try to find the abnormality here? It is not very easy, but I am trusting in you that someone of you will be our star again. So yeah, nice. You check for the line. Yes, perfect. The paraspinal lines. You remember the lecture of spinal paraspinal lines, tracheal stripes. So there is widening. I agree with you. And maybe, yeah, I wait something else. Can you go more further and try to find? Yeah, perfect. So maybe there is some adjacent dense vertebrae, yes, and paraspinal line is widened. Here, do you see here or here? Okay, let's go to the MRI, maybe confirm our appearance, and we can see that there is disc narrowing, as you mentioned. Then in the MRI, you are talking about term, you describe it by signal intensity. So is it increased signal intensity or decreased? It is increased, and you can see the paraspinal soft tissue. Yeah, Shayma, Marwa, Ala. So the most important to mention in this top differential discitis. It happened in the end plates, blood-borne infection, as you know, lumbar spine usually, staph aureus, they like it in MCQ, disc height, and irregularity or erosion of the end plates. So this is your key. And as you see in the X-ray, it will be paravertebral shadow. Sometimes they like to start with you about your approach in the X-ray for cardiomegaly. So you find this appearance in pediatric age group, which is below 10. Yes, shunt vascularity, perfect. So you can see the increased vascular markings here, and there is cardiomegaly. So the most common one, it will be, and enlarged BA, pulmonary artery, and right atrium. So one of the most important to mention in the shunt vascularity, the atrial septal defect. Yes. They like to show you in the kidney, we mentioned it before, when you find much calcifications or stones. But this patient, if I told you that he is already 3 months old, so he's very young, and you find this echogenic medullary pyramids. So this one, it could be what is called medullary nephrocalcinosis. Yeah, medullary nephrocalcinosis. They like to mention in the history that this patient treated with furosemide, which is diuretic. So they like to show you this in MCQ. So be careful about if you find this in young patient. So you are talking about what is called medullary nephrocalcinosis. It also includes the medullary sponge kidney, as you mentioned, Ala, yeah, Nermine also, hyperbara, and renal tubular acidosis, milk alkali, TBN. Okay. This one is easy one. In the practice or daily practice, you saw it many times, I think. So it can be an ultrasound, and yes, thyroglossal, Nermine, Marwa, Reem, welcome. One of our stars here, yes. So thyroglossal duct cyst, midline cyst. And here they like to mention that you can see this component below the tongue base. So this one is above the hyoid and this one below the hyoid. They are connected together. Yeah. So this what's called thyroglossal duct cyst. This is like 90% of congenital neck lesions. Child. The pathway will be from the tongue until the thyroid gland, exactly from the foramen cecum, which is the tongue base. As you see, it can be infrahyoid or suprahyoid or in the hyoid lesion. Midline, but it can be also off midline. Sometimes it is not hypodense, it can be hyperdense or hypodense, okay? Maybe rem enhancing and maybe infection and surgery after. Sometimes they like to show you this in the technician. So if they show you this means that this patient have what is called lingual thyroid. Yeah, it reach the level of the tongue. So mass in the base of tongue. So this is what is called lingual thyroids. This one we mentioned it before, pleural based lesion. It can be many things, but it can be lipoma as well. Sometimes you cannot differentiate, or usually you cannot differentiate it between others. In the CT, maybe if you measure the density and you find below 100 minus, then you can reach it. When you go to the pelvic bones, again, when you find pediatric patient, how you can describe this appearance? So Ewing sarcoma will be differential, I agree, Marwa, Shayma. So the left iliac bone, how we describe it? There is the ostia reaction. What about the density? Yeah, permeative, lytic, and sclerotic lesion. It look like aggressive lesion. Like the flat bones, what you will search if you find Ewing sarcoma, you will search for bone metastasis, lung metastasis. So in neuroblastoma, you search for bone metastasis mainly, and in Ewing sarcoma, you go to search for lung lesions. So aggressive pediatric bony lesion can be Ewing sarcoma, osteosarcoma, neuroblastoma, leukemia, lymphoma. So again, the appearance, it can be in like this one in the scapula, flat bone again. So you can see the calcification and soft tissue component. So you are talking about differential, but you should include Ewing sarcoma. Yes. I will ask you, Shayma, chondrosarcoma, it can happen in this young age, or is more common in the old age? What do you think? So remember that we are talking about pediatric. Yes, thank you. Yes. So remember always when you see pediatric patient, which type of patient you have. This is like the solve the problem of the half of the question. When the examiner show pediatric, try to stop and try just to mention the differential of of the young patient, not the old patient. Okay, maybe if you don't find nothing, then start to think another. But at least lymphoma and metastasis will be with you in anything, old or pediatric. So then add something in the old, like for example sarcoid and in the old, and some tumors in your mind, multiple myeloma, and in the young try to save with you something like Langerhans infection and so on. Okay, and neuroblastoma. So right iliac bone with soft tissue component, again you will add Ewing sarcoma. Okay, thank you. So okay, this one is easy. Head and neck case. So retinoblastoma, why? Because any calcified lesion in the eye globe, it will be retinoblastoma. Shayma, I see some of our stars. Fauzi, okay, is present. Abbas and Hassan and others, they are absent today, but okay. I wish everyone is fine. Okay, so retinoblastoma, it will be one of the good differential. Enhancing intraocular tumor without extension beyond the sclera in the optic nerve in child with bilateral retinoblastoma. Okay, welcome. So it can be bilateral, can be unilateral, it can be also what is called trilateral. So the last one will be where enhancing mass in the pineal. So Marwa, if it is quadrilateral, where it will be? Supracellular. Ala, nice. Supracellular. Supracellular. Okay, so when you find calcified lesion and yeah, bilateral, yeah. Okay, so then you have some differential. When you find lesion again in this age group, then if it is not
BHPV.
okay, Fauzi, thank you. BHPV, persistent hyperplastic primary vitreous. If it is not retinoblastoma, then you are talking about this. Another differential, when you find this V sign, without calcification in the vitreous, so yeah, smaller in size, maybe retinal detachment, maybe what? Maybe also something called, yeah, Coates disease. Yes. Sometimes there is one type of endophthalmitis happen in the young age. It's called Toxocara endophthalmitis. Just put in your mind. It happened also without calcifications. Again, shift to the genitourinary. When you find bilateral hydrouretero, but is much advanced, and hydroretronephrosis with dilatation and trabeculation. So trabeculation of the bladder, bilateral massive reflux, and some diverticuli. Yeah, Fauzi, Shayma, posterior urethral valve. Okay, it can be. And when you do this modalities, voiding cystourethrogram, it is easy to diagnose it. So dilated posterior urethra, and they have something called Spinnaker sail appearance. So this is what's called posterior urethral valve. The most common cause of urethral obstruction in male infant, either prenatal or after. Keyhole sign. The differential will be Brown-Belly syndrome, abdominal muscles obviously abnormal with bilateral obstruction. Okay. In the brown belly, there is cryptorchidism, yeah, and deficient abdominal muscles. I agree with you. So posterior urethral valve, like this one. So what happened here? You can see the bladder strabiculated, hypertrophied. Then the bladder neck even hypertrophied. And you can see the demarcation between the bladder neck, the bladder and bladder neck and the posterior urethra as dilated as you see here. Okay. Bilateral reflux, massive reflux, and hydrourethral. Is it easy? We can shift. Okay. CT with patient have sinusitis. You can see it, but he have like obviously like orbital pathology. So how you connect between both? Yeah, it can be sinusitis and there is a spread. So what happened here? It's called, yes, agree, Shayma, Nermeen, Ala, Marwa, our big stars today, orbital cellulitis. Yes. So don't forget the relationship between the orbit and sinuses. So check always for sinusitis. Then I will ask you, Ala, again, the same question. Take care about the age. Okay, we are talking, yeah. So maybe you mean pseudotumor by the infection, right? Not by the other type of pseudotumor, like IgG4 and so on, right? So I agree with you that when you find sinusitis, it can include the orbit pathology. It can make orbit pathology or cause orbit pathology. And this is the big relationship. Yeah. Sometimes they like to show you to this, and this patient have a problem like a respiratory distress syndrome. Sorry, this
Inguinal atresia.
Yeah, choanal atresia, respiratory distress, and he have closure of the choana, posterior nares. So this is what's called choanal atresia. It can be bilateral. Then he have much respiratory distress. Then search for other anomalies. Yeah. So this one, maybe this, he will mention in the history that this patient have maybe some mental troubles. He is a bit, yeah. So this is bezoar, nice. This is what's called gastric bezoar. There is sometimes mottled appearance and gastric filling defects. So trichobezoars happen in the older children, and lacto, it happen in infant. So as you mentioned, it is just have this mottled appearance. Then the history will give you the upper GI, you will find the mass not connected to the gastric wall, best seen in delayed films. The complication, much complications. So this is what's called gastric bezoar. You remember when we talk about the pelvis again and again, if it is not septic arthritis and it is not leg births, so search for this appearance. So here is much typical for slipped capital femoral epiphysis. Nice, Nermeen is easy one. Sometimes it's bilateral. Then you should try to make this line, what is called this line. You will try to draw it, and you should
Line.
Yes, this line, and you should find like part of this upper femoral epiphysis is cutting this line. If you're not, then you are talking about, yes, Sarah. Thank you. Welcome, Sarah. I don't see you in comment, but okay, you come back. Ragda also. We need to keep the stars with us. Really, you did a very nice job today. Slipped capital femoral epiphysis, idiopathic Salter type 1 fracture in the proximal femoral growth plate. Boys is more, yeah. They like the black and the obese. So this is the type of patient maybe come to you in the MCQ. The higher incident with hypothyroidism, hypopituitarism, renal osteodystrophy. Sometimes it come like bilateral, which is third of cases to take care. The most easy, if you find the frog leg lateral position, it is easier for you to. We like to show you this type of fracture, which happen in the pediatric age group. Now I give you the key, so it is easy. Just you can mention the, yes, what is called tubular fracture, which is oblique
Spiral fracture.
spiral fracture of the distal. Yeah, so this is non-displaced spiral oblique fracture with tubular fracture. Failure to walk. Yeah, okay. If they give you like a bone scan and there is increased uptake in the level of carpal of the tarsal bones, so in both sides, so we are talking about stress fracture. Thank you, Ala. Stress fracture in the cuboid. Sometimes the X-ray in this patient can be negative, so you need, that's why you need the bone scan. It is a result from forced plantar fracture. You will find just like tarsal uptake, it will be in the cuboid, as you see. When you talk about the skull, then in the pediatric, if you don't find the fracture, then maybe you should check the appearance of the skull. So the appearance of skull, they like it in MCQ.
Scaphocephaly.
Yeah, scaphocephaly. So the closure will be in the which?
Sagittal.
Sagittal, S with S. So scaphocephaly, which is type of the craniostenosis, can be primary or secondary to metabolic disease. So it can be like this one, and you are talking about scaphocephaly. So, for example, if you find this one, maybe there is what is called closure of, yeah, anterior frontal, like anterior coronal, bilateral coronal stenosis. For differential diagnosis, when you see X-ray pelvis, when you don't find septic arthritis, when you don't find Berthus, when you don't find scaphy or S left capital, then search for what? DDH. So what is the developmental dysplasia of the hip, which is abnormal development and configuration of the acetabulum because of increased ligamentum laxity around the hip. More common this one in the females. Okay. So it is the opposite of what? In the age, in the type of patient?
Opposite of scaphy.
Yes, opposite of scaphy, which is obese black patient. Yes. So here, this is the angles and the lines you will try to. So as you see here, the ossific center of the capital femoral epiphysis, symmetrical and located in the joint spaces, right? In the inner lower quadrant. There is two lines here. One line is called H, which is Helgener, I think is difficult to pronounce, okay, and Birken, yeah. So, and this one is called Shenton line, right? Yes, okay.
And the acetabular angle.
And acetabular angles. So this is the angles, right?
And Shenton line.
Yes. And this is the Shenton line, Birken, and maybe you can just say H line, which is easy for you. Then you can see that these acetabular lines are symmetrical here, and it is acute. But if you go to the pathology one, you can see the dislocation. So if you try to make drawing for this, what we already mentioned, you will find that this one, it is not in the lower inner quadrant. Do you agree? Yes. And also when you describe it, you will tell that it is a small epiphysis. Nice, Ala. So dislocation and the small one in the right side. And maybe you can mention that it's like false new acetabulum here. So the acetabulum should be here. It is very shallow. Yes, Ala, perfect. The differential will be, yeah, I think the developmental dysplasia of the hip. So we already mentioned the lines. If you remember from our session, the angles, if you remember, increased in which syndrome we just mentioned from while? The acetabular angles, when it increased, it was increased in which type?
Mucopolysaccharidosis.
Yeah, nice, our stars. Thank you. This in the ultrasound, I am not expert in ultrasound, but you can see that he start to make like real-time sonogram. There is maybe lateral motion, yeah. Femoral head, yes. And they try to measure the alpha and beta angles. So the acetabular angle, he try to, so if he find the angle of 60 or more than, this maybe indicate that he have this acetabular maturity. Okay. Just maybe we check, yeah. Normal, the coronal line drawn along the echogenic edge of the ilium should intersect or bisect the femoral head. The alpha angle should be more than the 55%, should be more than 55 or 60 in otherwise. In transverse, this one the coronal and this one the transverse. No, this one also coronal type, but he told you that the transverse femoral head center directly over the triradiate cartilage gap. Okay. This one in the neuro is easy one.
Lysencephaly, type 1.
Lysencephaly type 1, which is type of, again, of migration. And it can be associated with cytomegalo infection. It's smooth with areas of pachygyria, smooth surface of the brain. So this one is pachygyria. And this one with, again, migrational disorder.
Band heterotopia.
Band heterotopia. Yes, band heterotopia. This we mentioned in neuro, but we revise it again. It's fine. And this one,
subependymal heterotopia.
Subependymal, which is heterotopic gray matter in subependymal location. This one is easy one, which is
polymicrogyria.
Yeah. So this one is pachygyria, and this one is polymicrogyria, subependymal heterotopia, and band heterotopia. And this one is the lysencephaly. When you find this appearance with lateral radiograph, and maybe you can see that there is some fusion of segments of the vertebrae in very young patient. So you are talking about what? Klippel-Feil syndrome, which is congenital bony fusion of cervical vertebrae in one or more.
Versus juvenile rheumatoid.
Perfect. Versus it can be differential with juvenile. Search for springal deformity of the scapula, high riding scapula, and the omovertebral bone. Some deformities and some anomalies. Okay. Again, when you find this striated nephrogram, maybe poor contrast enhancement medially,
Pyelonephritis.
it can be pyelonephritis, one of the good differential. Yes, Marwa, Fauzi. Okay. We mentioned this one when we talk about the elbow, and you remember the keratoi. So search for, in order, the keratoi, the capitulum, the radial head. Then go to the internal, the medial, then
Little قلبي.
trochlea. So what happened here? What happened here in A and B and C?
Avulsion of the medial epicondyle.
Perfect. So there is a avulsion of the medial epicondyle. I think this one is very important in the exam because, like, to know keratoi, tension injury of medial epicondyle, young patient, acute or chronic, the acute displacement of medial epicondyle as here. Yes. Don't forget keratoi, please. They like it in the exam. Very, very important. This one, we remember the scheme we do. Search for Falcus if you can find. But
Holoprosencephaly.
yeah, this patient's fetal MRI. So this is what is called like single ventricle or monoventricle. You are talking about a lobar holoprosencephaly. You remember this one when we talk about stone, Staghorn stone, and it have hydronephrosis. So XBN, which is densogranulomatous pyelonephritis, Marwa. Yeah. Then let's stop here a bit. Maybe it's good to know. So what happened here? Describe it. Yeah.
Cleidocranial dysplasia.
Ala, nice. Cleidocranial dysostosis or dysplasia. When the complete absence of the clavicle, of the right clavicle and the left clavicle already like fractured or absence. When you go here, what is the deformity in the skull? CCD, Doc, Ala, Sarah.
Multiple Wormian bones.
Multiple Wormian bones, bossing again. And here the hand, you have two hands today or tonight, trident of achondroplasia and claw of mucopolysaccharidosis. And here, what you have here, how we describe it? The carbon ossification, they mentioned that is delayed. Tapered terminal phalanges.
Tapered.
Long, yes, long and tapered, perfect. Nice. Marwa, Reem, Ala, yeah. Terminal phalanges, yeah, okay. And when you go to the pelvis, they like to mention that the iliac bone here is small or undersized. Yeah. And look the relation between the iliac bone size and the size of the sacroiliac joint, and also the size of acetabulum. Yeah. And the widened. Yeah, widened. So this is what's called cleidocranial dysostosis, autosomal dominant. Ossification defect predominantly involving the midline, so you can find absent clavicles, either complete or partial, white cranial suture with wormian bones, white symphysis pubis, as here, and hypoplastic vertical iliac wings, rounded femoral epiphysis, tapered terminal phalanges, pseudo epiphysis of the metacarpal and metatarsals, and long second metacarpal. Okay. Another appearance of craniocrinial dysostosis with widening symphysis pubis. And the iliac bone, you can see the deformity, and the coxa vara as well. Here is good to mention the coxa vara differential diagnosis and the coxa valga, and also the wormian bone differential diagnosis. So young patient with osteogenesis imperfecta and wormian bones. So you have this differential. I don't like pork, but okay, this is the differential rickets, biconocystosis, osteogenesis imperfecta, cleidocranial cystosis, and so on, even down. Marwa, normal number wormian bones, 8 to 10. Above 10 is abnormal. Thank you. Yes. So normally it's from 8 to 10, and above 10 it will be abnormal, right? You mean this for the wormian bones? Okay. Thank you. Yes. So maybe we should mention this one, which is the abdomen of this infant have distension. Thank you. The source is Oxford about the wormian bones. The source of Oxford book of Pediatric. Thank you. Very nice. Very nice addition. This infant have big flanks, bulging flanks. Yes. So what does mean if you have this bulging flanks? That maybe there is distension of the abdomen, and if I show you this one, bilateral vesico-ureteric reflux, more dilatation of the lower ureters, again distension of the abdomen. Then I show you this one with the cystogram. So do you remember now the difference between the posterior urethral valve and the brombelly with abdominal wall deficiency, maybe bilateral cryptorchidism or undescended testis, hypoplasia, and here dilatation of the ureters. And here you can see that the no obstruction of the posterior urethra. Just it is dilated, but there is no obstruction here. So large urinary bladder and dilated posterior urethra, and there is even reflux, but in the prostatic uretrical, yeah. You see this one? So this is what is called brombelly or the eagle, Barrett syndrome. You have two eagles, maybe more than two, but at least you have one in the stylomastoid in the head and neck, and you have one brombelly. Is now is more famous with brombelly syndrome. Triad of dilatation of the collecting system and deficiency of abdominal muscles and cryptorchidism. We mentioned this criteria much. Let's shift to this one. This patient show that's newborn, and maybe you can see that there is something in the gastric location with these bubbles. You remember the bubbles, we gave you approach of the bubbles, but the rest of the abdomen is gasless. So You remember the bubbles, so it will be 1 or 2 or 3, maybe 1 bubble or 2 bubbles or 3 bubbles, maybe multiple atresias. High obstruction with enema show marked microcolon as well. So he already have dilated duodenum, and he have gasless abdomen distal to the level of obstruction, maybe, yeah. High obstruction, there is marked microcolon, so maybe another atresia down. So this one, it can be jejunal atresia, but in this level, you already have something with multiple atresia. I think I showed this one with esophageal intubation before, yes. This one is one of the easy one that they like it in the spotting or in the exam, yes. To show you this curvilinear opacity, which is reaching the, so this is what is called scimitar, which is venolubar syndrome, hypogenetic syndrome. Okay? Yeah, venolubar syndrome. So you remember thumb sign from last time? We mentioned it. It is the epiglottitis. And when you find the steeple sign but symmetrical, you remember this? It is what is called croup, acute laryngotracheobronchitis, acute upper viral obstruction, viral. So epiglottitis, this one, marked enlargement of epiglottis, thickening of epiglottic fold, ballooning hypopharynx. Or this one, which is croup with a steeple sign. Yes. You remember when you find lytic lesion, and don't forget the zone of transition and so on. And when it reaches the epiphysis, then it can be infection. And one of this infection, it could be the Brood's abscess. Usually it starts from the metaphysis. Yes. And it have like this sclerotic margin with penumbra sign. Thank you, Ala. Yes. So what you mean by penumbra sign? Finger-like projection. Yeah. High signal intensity. So this is what is called Brood's abscess. Yeah, when it's surrounding the lesion like a penumbra, so it is Brood's abscess. Okay, thank you. Widened intercondylar notch, maybe soft tissue tumefaction here. In pediatric patient, don't forget hemophilia to put in the top differential view. Yeah, differential diagnosis will be juvenile, but with this soft tissue, maybe you will find hemophilia is more suitable. Can be septic, yes. Can be many differential, but don't forget hemophilia. Yes. We are about to finish. This one, they like
Scaffold disease.
Yes, cafe disease. They like to show you this appearance with deformity, otosclerosing periostitis, mandible, and maybe soft tissue, and also this is appearance of the forearm and legs. So this is what's called cafe, which is cortical hyperostosis, but in infant. Yeah, 3 months until 1 year, this characteristic age. It involves this bones treatment steroids. This one with tibia vara, what is called?
Blount
Blount disease. Welcome, Marwa. Yeah, osteochondrosis, medial aspect. You know it is easy. Is type of osteochondrosis or osteonecrosis, Blount disease. We mentioned this
Charcot.
one. Yeah, Charcot joint can be in the pediatric age group. Then search for
with syrinx.
central, yeah, syrinx. When you find the shoulder is much deformed in young patient with this Charcot appearance, then search for neuropathic Charcot joint. This one is anti-many cases. It's very easy for you, for our stars, which is the Kienbock, yeah. Kienbock disease, which is type of osteochondrosis as Blount in the leg or the tibia and in the unitus Kienbock. Okay. So young child. They like to show this X-ray. Then you will describe something here. Then ultrasound. Then you describe a mass.
Fibromatosis coli.
Yeah, fibromatosis coli. So this is the order they show you to try to find. So don't forget it because
Torticollis.
it is non-neoplastic mass like or focal enlargement of the sternomastoid muscle. So it is just physical therapy. So yeah.
It's fibroblast proliferation inside the muscle.
Perfect, yeah. So in the X-ray, it's much difficult because you mentioned a lot of tumors and a lot of bad things. But in the ultrasound, it's much easier because you will think about the sternomastoid focal enlargement, which is fibromatosis coli. You like it in the MCQ. You will find many questions about torticollis, especially when they mention torticollis. This one is syndrome, deformed tower-shaped head, premature fusion of all cranial suture, not common, but
Torricephaly. Apert syndrome.
oxycephaly Apert syndrome, yes, premature fusion of coronal sutures.
With syndactyly.
Yeah, with syndactyly, yeah. Mitten hand deformity. You see more hands today. Syndactyly, mitten hand, multiple abnormalities. This is what's called Apert syndrome. Craniosynostosis with syndactyly. Don't forget the scaphocephaly, which is the most famous one, sagittal suture. The other type, sometimes they like to ask you in the MCQ. This one is easy.
Grade 2 reflex.
Okay. So type 2 reflex. Why Nermeen or Marwa?
It is a mild dilatation.
Mild dilatation, yeah. And they like to show you, is it reaching the calyces or not? Yeah. So maybe this type 2, maybe. Okay. Reach the calyces without dilatation. Okay, thank you. Without forniceal dilatation. Okay. Okay. This one is easy one on the skull, calcifications. Just you can mention many things, but if I show you
Weber syndrome.
Yeah, the CT, it is much easy to mention the Sturge-Weber. When you find low chord below L2, then search for lipoma. So it is
Lipomyelomyosarcoma.
maybe, yes. lipomyelomyelin and tethered core. So we are talking about tethered core. So search for the type of dystrophism. There is association of myelomeningocele, and when you find tethered core, search for the lipid component, lipomeningocele, and the reverse. If you find like lipid, search for the tethered cord, as we mentioned before. So I hope that you enjoy this pediatric. This is our final session, and I will wait for your feedback. And we can start, inshallah, we can find the new season for you. I hope everyone enjoy this final revision. We already finished neuro, GI, musculoskeletal, genitourinary, pediatric, and mammography. So we already cover all. I will try to put all the, inshallah, the videos in the YouTube channel. And Dua, thank you for your suggestion. It is not my specialty. I will maybe try to find someone who is special in intervention. Then he can give you the tricks in the exam. So maybe if we'll try to find, inshallah, next time, inshallah. Yeah, we will find the way that your suggestion is appreciated. So let's see what you need. My suggestion or my approach that we need, yes, better session. Okay. So better in the group, better, because I now is about in my time is a bit late. So okay, let's stop here. But please, I need your chat in the Telegram group. Then we can discuss together everything. Thank you, everyone. Hope sorry for about the today long session. Thank you. Assalamu alaikum.